Welcome everyone to our Leadership Academy project series. It's lovely to have you all joining us today. My name is Sarah Adams, and I am one of the graduate students assisting the American Indian and Alaska Native Leadership Academy. Today we are hosting the 5th session of the Leadership Academy project series. The American Indian and Alaska Native Leadership Academy is a one-year-long program for behavioral health professionals and Native communities. It is a mentor-mentee program focusing on peer connection, networking, and developing leadership skills. The program includes virtual and in-person training, and each mentee works on their own community-based initiative throughout the project. During this series, the Leadership Academy 3 and Leadership Academy 4 mentees will present their work to you. They will be discussing their on-the-ground initiatives to improve important aspects of American Indian and Alaska Native well-being. The series addresses different aspects of community health and describes projects that have impacted people around the country. This session is presented to you by the National American Indian and Alaska Native PTTC and ATTC located at the University of Iowa. As you can see from this slide, we are part of a national network of technology transfer centers. This program is funded by SAMHSA, but the content and opinions expressed today do not necessarily reflect the views and policies of our funder. We are currently on the 5th session of this series. Today, we will hear from Melanie Hazle regarding the implementation of trauma-informed care into primary care settings. Here are a few housekeeping things to address before we start. After the event, you will receive a follow-up email with a link to this session's recording. Within that email, you will also receive instructions on how to receive a certificate of attendance. At the end of today's presentation, please take a few moments to give us feedback on the event. We will share a link to the evaluation in the chat towards the end of the session. We are so thankful for your attendance today. I also want to extend my gratitude to Monica Dreyer-Rossi, our program director. Thank you to Taylor Magnuson, the other graduate student working on this project and assisting today. Lastly, thank you to our center director, Dr. Angele Skinstad. Although we are gathered virtually today, we want to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. I will give you a moment to read our center's land acknowledgement, authored by L.A. Driscoll, Keely Driscoll, and Sean A. Bear. Thank you. Today, I am very excited to introduce our presenter, Melanie Hazle. Melanie is located in Oklahoma and is a licensed marital and family therapist for the Lawton Indian Hospital Service Unit. Melanie is very engaged in her community, doing innovative work promoting mental health and well-being. She is mainly focused on populations that have experienced trauma. During the Leadership Academy program, Melanie worked on a program incorporating trauma-informed care into primary care settings, and that is what she'll be presenting on today. Throughout the session, you are welcome to post comments in the chat. We will be keeping all questions to the end of the session. So if you have any questions, feel free to post them in the chat and we will get to them at the end, or you can save them to the end when we'll have a discussion. So without further ado, I will introduce our speaker, Melanie. Welcome, Melanie. We're glad to have you here.
Thank you. And again, like she said, my name is Melanie Hazle. I'm a licensed Maryland family therapist here at the Lawton Indian Hospital. I'm also an enrolled member of the Choctaw tribe of Oklahoma, and I work in an integrated behavioral health setting. So I'm embedded in the primary care clinics, and I work alongside the doctors and the nurses. And I see patients who come in and have an appointment in any of our clinics and then want to visit with someone from behavioral health. And so I provide more brief therapeutic interventions. Some of those turn into full-length counseling sessions. And so that way the patient has an opportunity to be seen and have their, any immediate needs addressed, or even any, history of any type of mental health or behavioral health concern addressed. And I also wear a lot of other hats here at the facility. I have been our Zero Suicide Program Manager for about 4 years. I also lead our Zero Suicide Advisory Council, and I also participate in our HOPE committee meetings. Recently, I was in a group of emergency room physicians and other behavioral health professionals to seek PACE accreditation, which is pain and the pain and addiction care in the emergency room. And so that's been something that's been new for us here at the facility, so that we're able to address, patients' needs throughout the ER as well. The rest of my bio is there. I will allow you, to read that. I do believe you all are going to receive these slides, but just for the sake of time, I didn't want to read the whole thing to you. But I do, like I said, a lot of types of interventions. I'm trained in various evidence-based practices, and getting accepted to the Leadership Academy was something that I was really happy about, because I felt like my work here, this added another way to really be able to reach patients and do some things that I felt like, weren't happening in our clinics at the time. And so the Leadership Academy was really instrumental in kind of helping me to get this project off the ground. And so I will start then with my project. Next slide. So again, my project was implementing trauma-informed care in primary care settings. And I will say that through IHS, I think that we have come a long way in being more trauma-informed. I believe now that every year we actually, all staff members have to complete a trauma-informed care training. And so the biggest component of my project was being able to screen for trauma in our primary care clinics, because that's something that wasn't being done. And I will talk about that in a couple of slides in just a bit. Next slide. Trauma, according to SAMHSA, is described as the events or circumstances experienced by an individual as physically or emotionally harmful or life-threatening, which results in adverse effects on the individual's functioning and well-being. And we know there are various types of trauma. If you've had any types of training in trauma, you often hear of those types of trauma. And some of the ones that were really important to me in my project were the cultural traumas, the historical, the generational traumas, and even the current traumas that our patients are experiencing on a daily basis. Traumas can be single events, they can be prolonged events, it can be an event that has occurred throughout generations. We know that the American Indian and Alaskan Native population has disproportionately higher rates of mental health issues, medical issues, and even suicides compared to other populations. And being the population that I work with every day, this was something that was really important to me. And we know, that some of these events have occurred for various reasons throughout history. There was, the intergenerational traumas that, from factors like forced assimilation, the traumatic losses that occurred. And, these resulted in a lot of different problematic social situations for the people. the American Indian and Alaska Native population. And so again, that was something that was really important to me to be able to address that. Next slide. The ACEs study. Most of us probably in the mental health field are familiar with the ACEs study. It was one of the largest investigations of the impact of negative experiences, life stressors and stressful events over the course of an individual's lifespan. And being a screening that we don't do here at our facility, this was something that I really wanted to make a part of our primary care visits. Next slide. So again, being one of the largest investigations of childhood abuse and neglect and household challenges, the ACEs study is categorized into 3 groups: abuse, neglect, and household challenges. There were over 17,000 participants from Southern California completed the survey regarding their childhood experiences and their current health status and behavior. All of the ACEs questions were affiliated with the person's first 18 years of life. Almost 2/3 of the participants had at least one ACE score, and more than 1 in 5 had 3 or more ACEs. As the number of their ACEs increased, so does the risk for negative outcomes. 1 in 6 adults experienced 4 or more types of ACEs, and at least 5 of the top 10 leading causes of death are associated with ACEs. Preventing ACEs could reduce the number of adults with depression by as much as 44%. These are some of the outcomes that came from the study. And again, something that I thought was very significant is the fact that what the ACEs study revealed was just the effect, the impact that these different life stressors had on a person's overall health throughout the lifespan, again, was a contributing factor to why are we not doing this here, especially with a population that has, a large proportion of medical health issues. So, one of the results of the study, it showed us that, a lot of these traumatic events are linked to behavioral health concerns. Even, knowing that trauma impacts the brain, we talk about neurodevelopment, and without getting into epigenetics too much, because that could be a completely different presentation, epigenetics is telling us that a person's life experiences such as childhood trauma have a biological impact on the way that their DNA is expressed, and how that can actually be passed down. I don't know if any of you are familiar with Dr. Rachel Yehuda. She did a study on survivors of the Holocaust. And if you have not read her study, I encourage you to do it. It is very interesting and has a lot of information about the impacts of trauma. And through her study, she found that childhood or children of Holocaust survivors actually were affected by trauma, and it even was expressed in their genes. So very interesting study. And so the ACEs study has showed us the impact that the brain, that trauma impacts the brain in a way that can increase risk-taking behaviors. It makes people more susceptible to substance abuse, increases the likelihood of addiction, increased depression, and even the risk of various health conditions. So the ACEs study was really helpful in identifying that strong connection between ACEs and problematic health outcomes. There were some drawbacks from the ACEs study, some of those being the participant pool. If you're familiar at all with the participant pool of the ACEs study, you know that all of the study participants had insurance. They were all HMOs. Many of the original participants of the study were also from middle to upper socioeconomic status. At least roughly about 70% of them identified as Caucasian, and about 3/4 of them had attended college. So we're talking about a select group of people. And we also know that Native Americans weren't represented in the original ACEs study. However, the ACEs study did, generate other studies that did include Native Americans, and I'll mention that in a few slides as well. Next slide. The prevalence of childhood trauma, again, just looking at that, ACEs are common, and I think that was something that came out of this study, that wasn't known prior to this. The effects of these ACEs do add up over time. When we're talking about the number of people that had at least one ACE, and 16% of the study had 4 or more types of ACEs. Females and several racial ethnic minority groups were at a greater risk for experiencing 4 or more ACEs. The life expectancy of an individual with an ACE score of 6 or more may be reduced by up to 20 years. And again, we know that some populations were more vulnerable to experiencing ACEs because of the social and economic conditions in which they live, they work, and they play. And part of that we're talking about includes the population that I work with daily, and many of you may work with daily as well. Next slide. Again, this is just giving some more statistics on the ACEs study and what they were able to find. In their analysis between their exposure to the ACEs and the health outcomes, the authors determined that the adults that had the greatest exposure to ACEs had higher odds of chronic health conditions compared with those reporting no ACEs. And what I found very impactful was, for example, it says an individual with an ACE score of 4 or higher was 260% more likely to have chronic obstructive pulmonary disease than someone with a score of 0. They were 240% more likely to contract hepatitis, 460% more likely to experience depression, and 1,220% more likely to attempt suicide. And if you break that down even further and you're looking at, had these experiences been able to be reduced, this could have reduced the number of adults with heart disease by as much as 1.9 million cases. It could have reduced the number of people who are overweight or obese as much as 2.5 million people. And even the number who had depression could have been reduced by as much as 21 million had we been able to identify these and be able to reduce some of the impact of the ACEs. Again, a huge impact on why I chose the ACEs as my project. Next slide. Again, we know American Indian and Alaska Native children are more likely to have experienced certain ACEs that can have negative effects throughout their lifetime. We know that many are living in poverty, they've witnessed domestic violence, they have seen violence in their neighborhood. Many of them might have lived with a parent who was a substance abuser or a parent who has passed away. Many have divorced parents. You can have divorced parents and have an ACE score of 1. So very impactful. Like I said, we also have to consider the concept of historical trauma when we're trying to think about the impact of ACEs on the American Indian and Alaska Native populations. Next slide. So many studies on ACEs, they don't include samples that are adequate for separate findings for the American Indian and Alaska Native populations. And oftentimes, I'm not sure if many of you go and look at statistics of things, when you see the other listed as a statistic, that's often where Native Americans are categorized underneath the other on a statistic. And so American Indian and Alaska Native population, we're very unique in our culture. We have history, we have traditions. All of these things are very important to us. So, like I said, as far as statistics, we're often grouped under this other category. And we're thought to be more representative of a monolithic group, which is not at all, who we are or even a way to describe us. Prior ACEs work with groups in South Dakota, Minnesota. I know there's the Philadelphia study, Washington. All of these have now incorporated American Indian and Alaska Native. So finally, we are doing some work on ACEs that actually is impactful to the population that we serve. Next slide. Again, this was something, even when I visit with patients, sometimes we may talk about adverse childhood experiences. Many of them ask me, what is that? Or, what are you talking about? And so whenever I was trying to choose a project and was thinking about what's the most impactful kind of overall, when, as part of the Leadership Academy, you're asked to talk with elders. And in talking with elders, one of the biggest things that seemed to be the main theme of those who I talked to was, what are we doing about trauma? And so again, it was very impactful for me to say, this is, what I want to do with my project. When I set out to be a therapist, I never thought that trauma would be something that I was going to specialize in, but for whatever way, whatever reason, it found me, and it's actually been something that I've truly enjoyed working with trauma patients. And so this project, like I said, it is near and dear to my heart, and wanting to make that impact. So, and what I found is that a lot of people really don't understand ACEs. They don't understand the impact. I work with people who are even clinical of a medical nature, and they might be aware of ACEs, but they're not exactly understanding the impact of that. And so, preventing ACEs, we now know, can help children and adults thrive. It helps to lower those health conditions, those mental health conditions, helps to reduce some of those risky behaviors of substance abuse, improving education and employment potential when we're able to address those ACEs early on in an individual's life. And the biggest part of my project, stop ACEs from being passed from one generation to the next. Next slide. So this is the facility where I work. Very interestingly, I was also born at this facility. So in a way, this is home to me. You can see on the screen here, these are the different screenings that we have here at our facility. When you walk into our facility and you have an appointment, you're receiving a variety of screenings getting into that appointment. Some of these are just your typical, medical screenings that are done every 3 months, 6 months, depending on health. And then there's the screenings that the nurse is doing as you're coming in to see the doctor. And then when maybe you're meeting with me and I'm doing a PHQ-9, I'm doing a GAD-7, or I'm doing a variety of different screenings, depending on what it might be that you presented with. And something new that we recently started also is now the Columbia suicide screening is a part of our GIPR screening here at the Lawton Indian Hospital. And so I was really happy to see that as part of the GIPR screening. I know it's hard for patients sometimes when you throw changes in, but it was another way to make sure that we're not missing anybody. And so when I got to looking at just a variety of screenings that I would do on a daily basis, there's questions about alcohol use. There's questions about, do you feel safe in your home and violence? And again, when I was looking, for ideas for my project, I'm like, there's not a question on here that really addresses trauma. I mean, yes, we're asking about violence, or we're asking about substance abuse, but that was where it stopped. And so again, it was very important for me to do something that made a difference and be able to connect with those patients that we could be missing a lot of things because we're not screening for trauma. Next slide. Again, we're back to that definition of trauma from SAMHSA. And as mentioned earlier, the cultural traumas, the historical traumas, the intergenerational traumas, and the current traumas are really something that, that I wanted to hone in on with the population that I worked with. And so that is what made me choose my project. Next slide. So the title of my project was Implementing Trauma-Informed Care Screenings in your Primary Care Setting. And so what I set about to do was to implement these screenings, and so that we're able to identify patients earlier on in life and be able to act to get them connected with resources that would be able to alleviate, minimize the chances of some of these ACEs impacts later on in their life. Next screen. So what does it really mean to be trauma informed? And I, like many of you, have sat through probably at least 10 trauma-informed screenings, if not more. And you hear a lot of different things about trauma-informed care. And really, just kind of to narrow it down in a nutshell, it's really having that lens to look at a person's behavior as a trauma response or a coping mechanism, rather than seeing the behavior as only problematic. And I noticed in the primary care settings, I might have a patient referred to me by a doctor, and they said, well, I don't know why he's doing this, or I don't know why he's doing that. Or why is this person so non-compliant? Or, why is their behavior always this way? And we had some providers who were like, I want that patient taken off of my caseload because, they're this, they're that. A lot of times when we're not trauma informed, we fall back into patient blaming. And trauma-informed care is really having an idea of a way to look at that, to see that that behavior is a symptom of something that's much larger than what they're presenting with that day. And it's seeing the behavior as something that can actually be corrected. Next slide. The target population for my project was every patient that walks through the door. Again, just like you have your routine screening to come in to see the doctor, wanting to connect with those patients and be able to see what's going on and how we could, be of further help. We especially wanted to see those patients that have multiple health issues and chronic health issues, those patients that have behavioral health and mental health concerns, the patients that the primary care, basically their primary care doctor is the ER because they're really not established, they're, repetitive in the ER. We really wanted to connect with those patients as well to see how we could help and what could be addressed there. Those patients that have multiple doctor and ER visits also. And then the patients that aren't getting better. Maybe they are compliant. Maybe they are coming to the doctor, as they should, but they're still just not improving. Those are patients that we wanted to make sure that we're connecting with as well. And of course, any patient that has a high ACE screening score, we definitely want to see those patients as well. Next screen. And so this was my idea, is implementing these screenings at least twice a year in the pediatric clinic. Because, even a newborn, a parent would fill out that ACE screening for a newborn because we definitely want to know if that newborn is having any of these things occurring in the home, in their environment, so that we're able to intervene early. Adults, my plan was to have the ACE screening once a year for adults. And I will tell you in a minute too, a little bit about buy-in. When it came to getting staff to buy-in, people thought they were going to have to answer this screening every time they came here. No, just pediatrics twice a year and adults once a year. That way we're at least, being able to check in, see what's going on, and being able to intervene. There are some other trauma screenings in addition to the ACEs, the CATs, and the PCL5, and I'll talk about those more in just a moment. But again, like I said, we get those patients screened and we can see what their ACEs scores are, and then they're able to connect with an integrated behavioral health person at that appointment or have a referral to behavioral health for further assessment and follow-up. Again, the point is let's connect, let's intervene early and try to make a difference. Next slide. The CATs and the PCL5, and there are other trauma screenings. These are two that I'm very familiar with that I have used. And so this is the reason why I actually chose them, because one covers pediatric age patients and then one covers adults. The CAT screening is an assessment for PTSD in children and adults. There's a self-report and a caregiver report for ages 7 to 17. It is DSM-5 based. And the CAT screener can be a standalone screener as part of a larger assessment in a clinical interview. It's, once you have the results of that CAT screen, you go over those, you review those with the patients. It also helps to validate the child or the youth experience, helps you as a provider to learn about key factors that are relevant to their therapy and their recovery, helps you identify some traumatic memory hotspots, trauma reminders, and even their own cognitions that they developed about the trauma and the aftermath of that trauma. It's a really important opportunity to assess immediate safety as well and to do important clinical activities to help support the recovery process for the child or the youth that's affected by the trauma. The PCL5 is not a standalone screener. It's used as, I believe the cutoff score on the PCL5 is a 33. And that just suggests that that patient needs further assessment to confirm a diagnosis of PTSD. Again, it's DSM based. It takes about 5 to 10 minutes to complete it, and it can be self-administered by the patient. So 2 additional screenings that more likely wouldn't be done in the primary care setting, but in your outpatient behavioral health clinic. Next. Again, implementing trauma-informed care is really shifting that focus from what's wrong with you to what happened to you. And I know we've probably all heard this, but it's really impactful because I even had inpatient encounters. They say, well, I wish the doctor could have said this, or I wish the doctor wouldn't have done that. And it really comes down to that being trauma-informed and how to kind of approach those situations. And So some of the things in implementing trauma-informed care is the foundational steps to move towards fully adopting that trauma-informed approach care, building awareness and generating buy-in for a trauma-informed approach. Again, when you have people who aren't of a clinical nature, who are in a position to make decisions, you really have to work hard on that buy-in. And I did. I will admit I had to work hard on the buy-in as to why do we need to do this. And part of that was building the awareness, realizing a lot of the things that we're seeing in the outpatient clinic, have a behavioral health component. We know behavioral health and our physical health have a huge relationship with one another. So part of that was just building that awareness of, helping to recognize the prevalence of trauma, that these ACEs are very common, recognizing that primary and co-occurring trauma diagnoses, do occur. And the supporting a culture of staff wellness, again, checking in on your staff even, that's from the person at the front door all the way throughout the clinic. They're all exposed to people's behavior as they come in. And, checking on them, making sure that they're doing well and that they even know how to, respond to that. When we're talking about hiring a workforce that embodies the value of trauma-informed care and training, that's where that training comes in, training all of your staff so that they are aware of the impact of, what ACEs are, what does it mean to be truly trauma-informed? And creating a safe physical, social, and emotional environment. This comes down to even what do your waiting rooms look like? What's your facility look like? How is the patient feeling when they are there? We all probably, I can't say we all, but I know me. I work in a hospital setting. My primary care provider is here, but I feel a little anxious about going to the doctor, and I see her every day. But, we have a lot of people that struggle, with coming in, a lot of people, just various things. So even kind of looking at the environment that your patient is in, and how conducive is that to them feeling safe, to not being re-traumatized by something that they could see or that could be occurring. So we definitely have to be mindful as far as being trauma-informed on being mindful of the culture and the practices that could even be re-traumatizing. And we really want to make the effort to being trauma-informed because, to strengthen that resiliency and the protective factors of those that we provide services to. And, we want to make the trauma recovery a part of their treatment plan. And this is where you collaborate with your providers, and being able to do that and being more trauma-informed. Next slide. Some of the clinical practices of helping to implement and being trauma-informed is involving patients in the treatment process. Again, I know as a patient, and then even things that I hear, I don't want someone to say, well, we're doing this or this, or we're not going to do this or this, because I'm a firm believer that every patient has to be their own advocate at times. And so we really want to be, more in tune with making the patient a part of that treatment process. What decisions are you including them in on? Is their care? And how are we going about that as far as being trauma-informed and including the patient? Again, there's training for trauma. Ask how you can make the visit more comfortable, less uncomfortable. For example, I have patients, that visit me in my office, and my printer is right next to where they sit. And I know based on, some of the things that they're presenting with and that they've shared, if I'm printing something out to give to them, I let them know this is going to print out next to me because my printer goes off and makes a loud noise right when it starts to print. And then I let them know, is it okay if I step over and get this? So that, I'm kind of letting them know what's going on. It's just what's making our patients comfortable, what's making them uncomfortable, and being, being willing as a provider to ask that question. What else can I do in the visit to make this, more or less comfortable? What is it that you feel like you need? I always start my visits off with tell me how I can help you, because that's why they're here. It's for me to help. And again, the training of staff in trauma-specific treatments is really important. Like I said, even from your front door, your front desk staff, there are trainings that are appropriate for those personnel. And of course, you would have different trauma treatment training for different levels of providers. But it's important that we have that to be able to be trauma-informed. Engaging your referral sources and your partner organizations or tribal communities, all of these are things that we can do in the clinical aspect to help to be more trauma-informed and implementing that trauma-informed care. Next slide. My goals of the project that I chose with the ACEs screenings and the trauma-informed care was to identify, treat, and heal trauma. I think it's interesting. I've been in so many trauma trainings where we talk about identifying, treating, and managing it, but rarely do I hear talk of let's heal that trauma. It is a process. It does not happen overnight, but we know that we can start to intervene early. We can make a lot of impact through ACEs screening and the results that we get to be able to start doing that. Allow patient collaboration in their treatment plan. Again, very important, something that is part of my project. I really wanted to drive home to those providers that I see on a daily basis is our patients, should be a part of what their treatment plan is going to be. Improve patient health outcomes. Again, early intervention, early identification, all of that is key to being able to do that. Reduce unnecessary utilization of providers, decrease medical costs. All of these things can be done through early intervention, identifying ACEs, and getting those patients, referred to care. Provide families with more resources for resiliency and improvement in ACEs screening areas. We are lucky that we have several tribal nations around us that have a lot of different programs too that we're able to refer our patients to if we don't have those here at our site. So it's really key in being able to tap into those resources and helping our patients. Implement early intervention by minimize or alleviate the effects of the long-term risks that we now know are associated with high ACE scores. And the last one, this is the I just mentioned, raising the physical, mental, social, and spiritual health of American Indians and Alaskan Natives to the highest level. Next slide. Taking action. So again, my plan was to start with twice-a-year screenings in our pediatric clinic. I had a pediatric physician here who took a strong interest in my project and really helped to get this going. As you know, our cohort in the Leadership Academy was actually extended because of COVID. So we actually had longer time in the academy, and so it actually gave me a little bit longer time to be able to try to get the buy-in that I was looking for and to raise awareness of some of these things. And so she took a really vested interest and she said, I really want to do this. I think this is important. And so she and I, talked a lot about it and trying to, let's start at the pediatric level before we try to add a new screener into our adult outpatient clinics. And so that's where we really wanted to start with the pediatric clinic. And like I said, if those individuals had higher ACE scores, and we were looking at, maybe even with a 2 or above, let's connect. Maybe they don't necessarily need anything right now, but we could at least connect with behavioral health, with integrated behavioral health, kind of assess and see if there's any other needs that maybe do need to be addressed. We definitely wanted to connect with those with ACE scores of 4 or higher because we know the impacts of that from the ACE study. Part of this, again, was collaborating with the medical provider with behavioral support and input for the patient's plan of care. I have, since Integrated started, I've been here at this facility for just over 5 years. And so I came as part of getting Integrated off the ground and running here. And it was difficult at first for medical providers to treat behavioral health issues. A lot of them wanted to just, immediately refer to behavioral health. But some of those were things that maybe didn't need like lengthy behavioral health care. So that's really where Integrated came into play here. And being able to be here with the providers, raising that awareness. I've done some lunch and learns and different things like that for the staff here to help raise awareness and to get that buy-in from the medical standpoint to say, this is why we need to, identify and treat ACEs. And so that's actually been helpful and it has improved every year. It gets even better with the providers immediately connecting with me if they felt like there was a need there to be addressed. And getting the patients established with our behavioral health department for follow-up care, or even, the behavioral health services and maybe where they're wanting to go. Some might go tribal or some might go, private outside of the hospital. The main thing is that we're being able to identify those things and that we are getting those patients referred and connected with care. The plan is to eventually roll out to other clinics for a one-time-a-year screening for adults. And again, the ACEs screening, if any of you have ever done it, it literally takes just a couple minutes to do it. So it's not like something that's lengthy, that's going to hold the patient up for a long time. So that's the plan, twice a year in pediatrics and once a year in adult care. Next slide. Again, a little bit about overcoming those challenges, with COVID really being one of the biggest challenges that we had, because it did halt everything. Because in the height of COVID, when things shut down, behavioral health, I believe, was the only department that was still working on site. And so I did a lot of telephone work that time, during that time period, with patients, just addressing a lot of different issues because of COVID, the fear of COVID. And so we weren't really getting to see patients face to face. The main patients who were being seen in the clinics at that time were like ER follow-ups, those with chronic health conditions. So there were days that I might not see a patient even enter the facility during the real height of COVID when things shut down. So that solved some of the implementation of my project, but it also was a positive because it gave me more time, to raise that awareness and to bring this to the forefront of something that we need to do here. Another challenge is being inclusive to all tribal nations and trying to find that common language, because through my work with Zero Suicide, I have actually worked with patients of tribal nations who their native language doesn't have a word for suicide or depression. They don't talk about that. And so that was something that I had to take into account on how to, work with that barrier and still being able to connect with those patients. Again, that administrative support and buy-in, it took a while and to get that, but it was possible, but it did take a while. The behavioral health staff buy-in, even there, when you're talking about additional screenings and things like that, there might have been a little bit of groans about what are we going to do? Do we have to do this? But again, they all understand the impact of why this is needed. So it just took a little bit, to get the clinic to say, hey, are we able to do this? But there was also the challenge of during that time, we were without some providers. And so we really didn't have the resource to refer to at that time. But we also, like I said, weren't really taking patients in the behavioral health clinic face to face unless it was like inpatient psychiatric discharges, those types of things. And so that also stalled as far as kind of getting that initial behavioral health buy-in. The interdepartmental support, again, some of the other outpatient clinics are like, will we be doing this? What does this mean for us? Again, it's just kind of having those conversations and being able to talk about why this is important and how we can make a difference. And again, that hesitation of providers in treating mental health concerns, that was a challenge in the beginning. Like I said, it's gotten so much better, especially since I am in the clinics with the outpatient providers, because we can consult with one another on what we feel is best and maybe what this patient's needs are and what's the best plan for the patient and all of us involved to address that. So that's actually improved since the initial presentation of my project. And again, the collaboration with tribal partners, hospital, tribal council, training, education, integrated behavioral health support to primary care clinics. These were some of the things that we did have the ability to do that was able to kind of help us overcome some of these things. And, so the biggest thing is, getting this rolled out to the pediatric clinic. And so when we started to do this, we lost some providers in behavioral health. And so that kind of stalled us from having that referral to say, we were identifying patients and really not having the on-site resource at the time maybe to address that. So that was really difficult as well. Next slide. If you've had any TSCBT or other trauma trainings, you might have heard this quote. I actually have this quote in my office. Trauma creates change you don't choose. Healing is about creating change that you do choose. And again, one of the biggest things from that ACEs study is just identifying that impact of trauma, knowing how that has affected, our populations that we work with. Numerous studies have been generated from that study. And even though the findings maybe, didn't include the populations we work with, the subsequent studies have actually had similar findings to the original study. So we know the value of the ACEs training and how that can help us. We know the research in this area is continuing to grow. We know that there's strong evidence that early toxic stress causes the brain dysfunction, and that in turn causes, these different health and life issues throughout the lifespan. And so this is really the basis of why I wanted to make an impact through implementing these trainings in a trauma-informed care at my facility. And I believe that is the end, Sarah. Yes.
Wonderful. Thank you so much, Melanie. That was very interesting. It was really neat to hear about how you took your interest in trauma and created a program from that to really help your community. So thank you so much for sharing that with us. Now we will open it up to comments and questions. So feel free to use the Zoom chat feature and input comments or questions in there. You're also, you're welcome to unmute and share any questions you have out loud. So we welcome those now. While people are thinking of their questions, I actually have a question for you, Melanie, if you don't mind. I'm interested in what the education looked like for the medical staff to implement trauma-informed care. You had mentioned the lunch and learns, but was there any other parts that were incorporated into that?
Some of that was just, like I said, I know that we, IHS has, we even have QPR training IHS wide now, which we didn't have even when I first came here, because I actually was trained to provide QPR training for staff. And so we had done that. So I know that IHS has recently taken on more of that. I do know even within our policy at IHS, there are, trauma-informed policies and things of that nature. So some of that was through the IHS trainings of the trauma-informed care. Some of that, we are a PCMH facility, and so I take part in our outpatient clinics are separated like into different adult care clinics, and even primary 1, 2, and 3, and then we have women's clinic, pediatrics clinic, and so I'm a part of each of those clinics PCMH groups. So I was able to, at their monthly PCMH meetings, go in and provide some different trainings and information about trauma-informed care and things like that. So that's been helpful in being able to reach the staff. And then we have some that just take it upon themselves that want to know more about this, and knowing that we're integrated, that behavioral health is right here integrated, and and being able to work and collaborate on patient care, that really made a difference in being able to get our staff, our medical staff on board.
Wonderful. Thank you. Are there any resources you'd recommend for somebody interested in learning more about trauma or trauma-informed care, such as a book or a website?
Most of us are familiar probably with The Body Keeps the Score. I don't have a list at the moment. I have several of books of my own because, like I said, I never set out, when I went to grad school and, decided to be a therapist, I never set out thinking, trauma is going to be something that I'm going to do often. And so when I worked, in the private setting before coming here, I was starting to get a lot of trauma cases. And so I took it upon myself to, learn even more about it. And that's really when I got interested in the ACEs studies, some of the other studies that have been conducted on trauma. And so I kind of just took it upon myself to do the different trainings. I've had some different trainings. I mean, I am EMDR trained, I have a TSCBT. One training I haven't done yet, but I would love to do is the DBT training, just to kind of complement those others. But I've done the TRIM training, the Trauma Recovery and Empowerment. I've done many, and like I said, if I find one and I'm like, hey, this is right up my alley, then that's what I choose to try to enroll in and do those trainings.
I admire how much you just keep learning and building your skill set. It's very impressive.
Thank you.
Throughout this process, are there any stories that stand out, either with staff or individuals, that you think kind of highlights the program's implementation?
I mean, so interestingly that you asked, because a lot that we've seen in the news lately with the boarding schools, I've actually encountered patients that were a part of those boarding schools. And so that's been really impactful to hear what they endured. And again, just kind of one of those things that motivates me even more to try to make that impactful change. And I mean, there's some pretty, horrific traumas that I've heard, and it's amazing to see the resilience of the, population that I work with, and, and how they have overcome. And, it's just, I wish we would have had this screening implemented a long time ago so that, we could have addressed these things earlier on, because even throughout the Leadership Academy meeting with, I think there was only maybe myself and maybe two more of the mentee group that were IHS affiliated. I think the rest were tribal. And so it was interesting hearing the stories how, a few of them were doing ACEs as part of their, screening process. And so, but most of those, I believe, were tribal, not IHS. So, like I said, it was something that I really kind of took to heart and wanted to do, to make that difference. And, I was reading some of the comments here quickly in the chat that, people have shared, and thank you so much for sharing. And I know that it's difficult to share things like this, so I definitely commend you for doing that. And it's and someone was mentioning that emotional and mental health care was not existed in the area that they were in, and that's unfortunate, because we do have that. I mean, of course, I'm in Lawton, Oklahoma, which we're about 100,000 people because of the military base, but a lot of our patients come from very rural areas. And so some of them drive a long way to get care. And so I can see, the impact of not having, that close by as well.
Thank you for sharing that. So I'll just leave a few moments in case anyone has a question or a comment. We would love to hear from you. Well, thank you so much for sharing your program with us today, Melanie. It was very interesting. I learned a lot. We really appreciate you taking the time to share this with us. I believe you have some references up here. And I want to thank all of you for attending today. If you could please take a few moments to give us feedback on this event, that would be very helpful. You can utilize this link or QR code to access the survey. You can also find that link in the chat. Taylor had posted that earlier. You will receive a follow-up email with a recording of today's session. Within that email, you'll also receive instructions on how to receive a certificate of attendance. We hope to see you again next Monday, June 19th at 1 p.m. Central Time for the next session in the Leadership Academy project series. Monica Super will present on the MODOC ancestral run and how to transcend trauma through connection. So we look forward to seeing you then. Thank you again for joining us today. It was lovely to have you all here.